I am one of 2 full-time faculty bioethicists. A lot of my work is clinical, so I round with physicians and see patients. I round with the care teams, do some education with residents and physicians, but I also teach anything from undergraduate to medical school to nursing school to any of them. A lot of the cases that we get, and we do about 180 consults a year, and a lot of them at least have an element of consent, even if that's not the main issue. Whether someone can consent, whether they have the capacity to consent to treatment or to refuse treatment is always a big question. Of all the cases we get, of those 180, communication is a huge part of every consult. Because a lot of times when we get consults, communication is broken down. It usually isn't that there's just something that they need my expert opinion on. It usually is they need help rebuilding communication. Because every age group has their own complexities and their own questions that come up when we're talking about consent. And they all have their own challenges. Pediatrics is different though, because instead of a dyad relationship, instead of 2 people who are having a conversation, you have kind of a triangle. So it's 3 people, a triad. The parents, the physicians, and the child. That being said, we all exist within a web of social relations. There are other members of the care team who may have opinions on what's going on. There are family members who are involved. There may be state agencies, insurance players. There are all kinds of groups that can affect treatment choices. Children, even from 4 or 5 years old, have some understanding of what's happening with their health care. And so, starting at that age, you just gradually try to bring them in to their own healthcare decisions. And we call that respecting their growing autonomy. Because as they get older, they're going to become more and more involved, get more understanding. And especially kids with maybe chronic diseases, bringing them in and getting them involved earlier and giving them buy-in into their own care helps. It keeps them involved. It sets them up for a better path as they become adults. And it also gives them some control over their lives where they may feel like they have none. Yeah. So in middle age, you may have a temporary loss of capacity. It may be that you've been in a car accident and you are sedated, for example, or you're just kind of not with it yet, you're recovering, and so you've just temporarily lost that capacity to make a decision. And you're going to get it back and you'll go and live for another however many years. There are studies showing that different age groups also have different preferences for decision making. So it's not just about whether they're able to make decisions, but it's also about whether they want to.
Yeah.
So we also need to look at those factors as well. Geriatric, in a sense, there's a way in which they're very similar to pediatric cases, because people assume that old people have trouble making decisions, maybe don't want to be involved, but these assumptions aren't warranted. And so, unfortunately, a lot of people do tend to treat geriatric cases kind of like pediatric patients. They're like, oh, well, let's call your daughter and see what she thinks, and so they kind of take away some of that decisional authority that older people have, sometimes without justification. Now, if someone isn't able to make decisions for themselves, if they're not able to understand or appreciate or reason or anything like that, then they shouldn't be able, it would be very difficult to make a decision for yourself in that situation. But when they're still able to do so, kind of bringing in the family just because you haven't gotten the answer you wanted to hear that kind of takes away the ability of that person to give consent or refusal. Age is a factor, but I think the context is a lot more of a factor. Obviously, age is a factor when you're talking about a 3-year-old versus, just an adult. But more than that, even, older people may tend to have other issues, but that doesn't mean that every older person you see is going to be senile or have Alzheimer's or something like that. So we really need to look to the context of the situation, that particular patient's condition and their own capacity, a lot more than we need to look at their age. But I think patient-centered care, where that really is important, is where we think about what are the goals that the patient wants to achieve. And unfortunately, we start asking them about is this antibiotic okay? Is it okay if I change your wound dressing right now? Is it okay if we do all these things? And get consent for every tiny little step. And it sets it up to, for refusal, while we lose sight of what the patient has said their goal is. And so we really need to balance patient-centeredness on what is the patient's goal, revisiting that goal, understanding where they're coming from, helping them to understand their prognosis, their diagnosis, why we're doing the things that we are, and yet still maintaining our integrity as healthcare professionals and doing what's best for our patients and coming up with plans that make sense so that we're not imposing a lot of harms without, some kind of compensating benefit coming out of it.